Hello, everyone. My name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. Today's event is entitled AHRQ's Physician and Physician Practice Research Database, 3P-RD for short. Okay, next I'm going to go ahead and introduce today's moderator. Xiaochu Hu is a research manager of workforce studies at the Association of American Medical Colleges, and she is also the vice chair of Academy Health's Health Workforce Interest Group Advisory Committee, who is co-sponsoring today's event. Xiaochu?
Thank you, David. Good afternoon. My name is Xiaochu Hu. I'm very happy to be here to moderate this webinar. Many thanks to David's team at the Health Workforce Technical Assistance Center for organizing and hosting this webinar. As one of the 19 Academy Health Interest Group, the Workforce IG's mission is to improve health and healthcare by promoting research and disseminating evidence that informs health workforce policy and practice. We organize webinars and events at the Academy Health Annual Research Meeting, as well as throughout the year, like this one. If you are interested in receiving information for our online and in-person events in the future, I invite you to join our research group and our serve listserv. It comes free with Academy Health membership. Please contact me or Janet Kaufman, who is our chair of the IG, for more information. Next, please allow me to introduce our speakers for this webinar from the Agency for Healthcare Research and Quality, AHRQ, Herbert Wang and Zainal Karaka. Dr. Wang is the director of the Division of Statistical Research and Methods at the Center for Financing, Access, and Cost Trends at AHRQ. Dr. Karaka is a senior economist at the Division of Statistical Research and Methods, also at AHRQ. Herb, please take it over.
Thank you very much, and thank you for that introduction, Yashu. So again, my name is Herb Wang. I am the director of the Division of Statistical Research and Methods here at the Agency for Healthcare Research and Quality, also known as AHRQ. Now, originally, my colleague, Zainal Karaka, and I planned to do a joint presentation, but unfortunately, Zainal was called away to deal with a personal family situation. So I'm going to be presenting on my own today. So for the next 40 minutes or so, I'd like to describe to you a new database that AHRQ has sponsored called the Physician and Physician Practice Research Database. Now, because I'm a big Star Wars fan, the naming of the database was intentional so that the acronym of this database is called 3P-RD, okay? And 3P-RD is really a larger AHRQ, is part of a larger AHRQ initiative called AHRQ Data Innovations. And AHRQ Data Innovation is an effort to really identify existing data gaps and to build a prototype database to begin to address some of those gaps. Now, the way that I have structured today's talk is I'm going to first start off by giving you some background on myself to give you some grounding of the way in which I think and Zainal thinks in terms of database building. Then we're going to move into the motivation for this particular data initiative. I'm going to be covering how we in fact built this database, high level overview, everything from the planning stage all the way down to the sharing stage, that is getting the database out to you folks there. Then there's going to be a section where I'm going to describe to you some descriptive statistics just to give you a flavor of what are in these databases so that you can be thoughtful about how you can use them for your own research purposes. And then I'm going to describe to you how you can, in fact, get the 3P-RD databases into your hands. And then we'll facilitate a Q&A area for you folks to ask us some questions. So let me quickly kind of introduce some of my background for you folks. I am in fact trained as an economist. I have worked here at AHRQ for over 30 years, and I have really spent my career conducting health research and policy analysis, as well as deeply involved in data development activities. My research expertise is really in healthcare markets. I'm primarily interested in hospital markets and physician markets. In terms of the data development activities, I have worked on the agency's flagship data programs, which includes the Medical Expenditure Panel Survey, also known as MEPS, and the Healthcare Cost and Utilization Project, also known as AHRQ. I am now leading the AHRQ Data Innovation Initiatives, and as I mentioned earlier, 3P-RD is really one of the many data initiatives that falls under that larger umbrella. Now, Zainel's not joining us today, but Zainel's background is also in economics. Similar to mine, his areas of interest is in the market space. So he has published extensively in that particular area. He's also trained as an econometrician, so that he lends himself in terms of different statistical methods that might be deployed in a variety of healthcare data. He's been an integral part of building these databases, and he's really the technical lead at the AHRQ end in terms of building the 3P-RD. When you have questions, you're likely to ask questions of us when you get through the agency emails, and we're the ones that are likely to be answering those questions for you. One final note before I go to the next slide is that because of my background in research and in data development, as well as Zainel's, I believe that we actually have an advantage in terms of building research databases that are in fact useful for the field, because we have been on both sides of that. Not only are we builders, but we're also users of the data and know the sort of features that are important from a research aspect. Next slide, please. So AHRQ is one of 12 operating divisions within the U.S. Department of Health and Human Services. And AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, affordable, and to work within the U.S. Department of Health and Human Services, along with other partners, to make sure that the evidence is understood and used. Now, AHRQ achieves its mission largely through funding healthcare research, but AHRQ also funds its research through grants, but it also conducts certain initiatives using a contract mechanism. In addition, as I mentioned a little bit earlier, AHRQ actually has a long history of database development and dissemination. And I mentioned the two flagship programs already, the Medical Expenditure Panel Survey, MEPS, and the Healthcare Cost and Utilization Project, AHRQ. Next slide, please. So over the last several years, there's really has been this growing recognition that the national healthcare environment has been changing. As new issues on healthcare delivery emerge, policy analysts are now recognizing that they don't really have the right databases to properly address many of these issues. And in general, there's this growing recognition that there are more data are in fact needed to inform public and private policy, especially to address issues related to equity, health insurance coverage, healthcare markets, and competition. Now, 3P-RD was particularly motivated by the COVID national emergency back in March of 2020. As the COVID national emergency emerged, the U.S. Department of Health and Human Services was seeking information to help inform how the CARES Act Relief Fund would be distributed. And the department approached AHRQ with many requests for information. Now, we were able to answer many of these questions with our existing data sources. For example, information about hospitals. There was, however, there was really no comparable information for physician and physician practices. And in general, the COVID national emergency really highlighted the serious data gaps that we have in order to inform policy. Now, if you take a look at hospital care in the US, that largely represents about 32% of the national healthcare expenditure. The next largest category is actually physician and clinical services, which stands about 20% of national healthcare expenditures. Now, AHRQ has really long recognized that there has been this information gap on physicians. And in the fall of 2020, AHRQ decided to invest some resources to begin to address this data gap. And that's how the physician and physician practice database, or 3P-RD, emerge as a way in which we begin to fill in those data gaps. Next slide, please. So what is 3P-RD? Well, 3P-RD are individual state-level databases that contains the census of physician and physician practices with attributes or characteristics that are useful for healthcare analysis. Okay, so it's both physicians and physician practices that the database largely represents. Now, the databases were constructed using raw data sources for the 2019 to 2020 time period. AHRQ had a lot of help to construct these databases. NORC was our prime contractor on this particular initiative. The individual states that we were able to create databases for include the following: Arkansas, Arizona, California, Colorado, Florida, Massachusetts, Maryland, Minnesota, Missouri, Montana, New York, Texas, and Washington. Okay. Next slide, please. So this slide illustrates how systematic and thorough we were in constructing the databases for this particular initiative. As you can see from this graphic, we really went through 6 different steps in order to get that. In the very first step, which we call the planning stage, we conducted a pretty thorough environmental scan to uncover the different data sources and availability of both physician practice data. We went through a process where we thought long and hard about what the database design would look like and how is it that we bring raw data sources and combine them together to produce the databases that we were after. We had many different conversations with experts in the field in terms of getting advice and further discussions. We also identified many data vendors in terms of about the potential of obtaining their data sources for this project. When we went into the acquisition phase, we had to basically think hard and fill out data request applications. There were data use agreements or memorandum of understandings that we had to negotiate. We had to, in some cases, purchase the data to acquire that. And then once we were able to get the data, we had to think hard about how is it that we receive that data, how we store that data, etc. Once the data became in-house, there was a systematic way in which we began to clean the data that we had. That is, going through a series of validation to check the quality of our data sources, think hard about data harmonization. Since we had so many different data sources coming in, we wanted to make sure that the information that were contained in certain data elements were in fact capturing what we thought they were correct capturing. When we went into the building stage, we thought about the actual data elements that we wanted to construct using our raw data sources. There were situations where we had to match different records to make sure that the linkage between physicians or physician practices were in fact the same entities or a person. Once we completed the building stage, we of course went into a quality control or testing phase where we benchmarked the different components of the data, checked for outliers, and making sure that different components adhere to the confidentiality agreements that we had with our data providers. And finally, the last stage, of course, is to create these different files and to begin to share them with the public. Next slide, please. So let me talk a little bit about our planning stage and evaluation stage. So when we began the project, our first thought was to try to find a series of common data sources that covered basically all states. And in this particular effort, we were able to uncover 3 data sets that got good information on physicians themselves. The first being the National Plan and Provider Enumeration System. For those people who are familiar with CMS sort of data, is the acronym is NEMPES. We also acquired data from the Federation of State Medical Boards. And finally, many people are aware of the American Medical Association master file. So those were 3 sources that we uncovered that covered basically all the states in the United States. A similar exercise focusing on physician practices. We were able to uncover data available from the Medicare data on provider practice and specialty, also known as MD Pass. We have information from the Provider Enrollment Change and Ownership System, known as PCOS. And finally, the Healthcare Provider Cost Reporting Information System, also known as HCRIS. All of those files come from CMS. We also looked at another data source known as IQVIA OneKey, which is a proprietary data source that is typically sold to pharmaceutical companies for the ability to market pharmaceuticals to physicians and things of that nature. But they have now expanded into the research realm where you can get a license where you can use their data to conduct research as well. So those were some of the data sources that we kind of explored that were common across all states. We also explored a number of data resources that were unique to states. That is, not all states will have these particular data sources. The first being health insurance claims information. The primary data source would be the state all-payer claims database, also known as state APCDs. We also looked at a number of other claims data sources, such as CMS fee-for-service files, Medicaid files, things along those lines that are health insurance claim information. And finally, we recognized that although we had information from the Federation of State Medical Boards, which is a more global entity, that individual states actually had their own medical boards as well. And so we reached out to those individual state medical boards to see what type of information they might have on physician practices. And finally, there were a scattering of other data sources that we considered, and that there were up to 9 different data sources. I only listed 2 of them here: the Association of American Medical Colleges and the Arts Compendium on U.S. Health System, just as an example of the types of data sources that we in fact covered. Next slide, please. So this in this graphic, we basically obtain the state medical board information from 21 states as our starting point. The graphic on the right-hand side showcase the states that actually have all payer claims data, that is state APCDs. As you can see in the orange, those are the states that had mandatory or some sort of existing APCD system available. There were other states that had volunteering efforts, and that is colored in a darker gray, and then the lighter color indicates that there was no APCD activities. So as part of our effort for this, we actually reached out to 7 state APCD And we were able to obtain data for 4 of those states for the purposes of this project. In addition to that, we obtained publicly available information on the MPES, PCOS, and the AHRQ compendium as another data source in terms of our build stage. Next slide, please. So once we were able to get all these data in-house, we went through that process of cleaning the data. That is checking names, dates of license, looking at full addresses. Remember, when we get data from a variety of data sources, they're not all going to be lining up one-to-one. And so it was quite a process for us to synthesize it and to deduplicate and to match all the information across all physicians and all physician practices. There was a fair amount of data assessment and harmonization that had to occur in terms of making sure that the information that we're capturing across one data source to another were actually, in fact, lining up along those lines. The core of our physician files were the ability to, in fact, link the state medical board information and the MPES information. And so we went through a process where we, in fact, had names of physicians, first and last name, and we used a method out there that is well known. I'm not familiar with this particular method, but the contractors are and Zinel are. But we did that particular match. Next slide, please. So this is just a graphic to illustrate the comprehensiveness of how we did the matching. As I said before, we started off with the MPES data and the state medical board data. We linked them up to create a file. Then we supplemented information from the PCOS files, focusing on the National Provider ID, where we created what we called the core physician file. All right, so it was quite a process to kind of whittle it down to this core physician file. Next slide, please. So this just gives you, this slide just gives you a sense of how we had to go through that particular process. A few characteristics to kind of highlight that in the core physician file, the information that we are obtaining is largely from the state medical board data. As part of the process, we created our own unique 3P-RD provider ID. As you can imagine, there are different ways in which individuals and entities can be characterized, whether it's a tax ID number and an NPI, et cetera. We created our own to make sure that we can really deduplicate all providers and all practices. So we are able to kind of track them across the different databases. A couple of other footnotes here is that by and large, we have information on license status, a few footnotes. As you can imagine, each state might have different sets of information. So in this case, Arkansas and Minnesota has information only for physicians who have active licenses. We do capture information such as license dates, that is when they got their, the physician got their license, physician names, their gender. Again, a few caveats. We are able to get information on, say, military affiliation for a small number of states, board certification, again, not for all the states, but a handful of states we're able to get. Medical school location, again, some additional states there in which we have information. So all of this required a fair amount of work in terms of us kind of harmonizing different information, especially specialty information, things along those lines. So as you can see, this process was quite detailed and quite comprehensive. Next slide, please. So in the final build stage, we at the very beginning had targeted the ability to identify 13 states for this prototype database that we are creating. In the end, when we finally created this, we did identify the 13 states. I'll get into that in a moment. Then we began to take a look at physician characteristics from the claims data that I had mentioned earlier. So we get basic information from state medical boards such as gender, licenses, education, things like that. But we're also hoping to tease out information from the claims data that might be useful for analysis. On the practice side, that is physician practice sites, we looked hard at the tax identification number or TIN number and looked at zip code to get a better understanding of their actual physical location. As we know, physical location might be important in terms of understanding workforce issues in a particular geographic environment. And then we went through a process in which we, in fact, developed physician practice characteristics from the claims data as well. Next slide, please. So in the end, we did select our 13 states for this prototype. We include 4 states in which we actually attain all-payer claims data from, and those 4 states include Arkansas, Colorado, Maryland, and Washington. We also included, as part of our 13 states, other states that had a APCD data program or were developing one, but we didn't have the opportunity to actually physically get their data. Again, part of the reason is timing of the project, and we didn't have an opportunity to really go through their full process in terms of acquiring their data because of that, and also because of resource limitation. But we included California, Florida, Massachusetts, Minnesota, New York, and Texas. To round out our 13 states, we also included Arizona, which really represented our southwest corner, Missouri, primarily because it borders Arkansas, and we wanted to do some comparison between states with APCD data and states that we were unable to obtain that data. And finally, we added Montana to the mix because it represented a nice rural frontier state. Next slide, please. So as part of our processing, particularly the claims data, all the variables that we process for claims are standardized. We have all states included CMS fee-for-service data, as well as Medicaid data and some other data sources in which we added the claims data. For only the APCD states, we actually have richer information because we also can include Medicare Advantage data and commercial data as part of those claims. So for the other states, that is non-APCD states, we do have claim information based on bullet point 7 here, CMS data, fee-for-service, Medicaid data, but we don't capture information on either Medicare Advantage or commercial data. Next slide, please. So this graphic shows how we kind of piece together the information to, in fact, create the research files that we were eventually kind of after. As I mentioned before, we created that core physician file using a number of different data sources. Then we went through a process where we began to process the claims data. So in the lower box there, that's just to illustrate the sort of information that we were able to tease out of the claims data. Everything from information on revenue codes, provider specialty, things along those lines, we were able to get out of the claims data. And again, once these slides are shared with you, you can peruse through them in greater detail. But what that does is, in fact, translate into what the research variables were going to look like. And so on the right-hand panel that is kind of in the orange color, you'll see the list of variables that we created for the physician files and those variables that were created from the claims file. Next slide, please. So this is just to highlight those physician variables that we were able to create. We would have a national provider identifier so that you can track that physician across the state and over time. There are different elements that we included, such as whether or not they are in fact an active practicing physician, information about whether or not they bill to the three different insurers, whether they bill for Medicare, Medicaid, commercial, etc. We'll give you some information about the patient that they treat, that is, the age range that they treat, how many claims they might have per month. So you can see that there are a list of information that we created for the physician that might be useful for analysis. So this is just to highlight some of those components there. Next slide, please. So we did the same thing, focusing on the physician practice variable as well. Again, starting with the core file, and we are blending it in with the information we got from the claims file. And from there, we're able to, again, focusing only on the practice, information that is useful in that regard. So information such as the organizational MPI, again, we want to identify just that one institution, try to deduplicate in many ways. There's state information, there's zip code of location, information such as the number of physicians that are associated with the practice. Again, you'll have an opportunity to take a look in greater detail of the information that we kind of were able to generate. Next, please. Next slide, please. So the physician practice variable, again, this slide here is able to kind of showcase and highlight some of those different components that we were able to get on the physician practice. Some things, again, you can go peruse through this, but some of the information that might be particularly interesting for the practice variable is what I call the fifth bullet down, demographics of patient panel. So this will give you a sense of the types of patients they're treating, everything from age groups to the share that are female, and some race categories such as non-white and Hispanic. We don't have information in great detail in terms of race, but we're able to capture some information along those lines. And again, some other characteristics that are kind of listed on the bottom here. Next slide, please. So some key characteristics of the 3P-RD files that we created. First, the files are completely linkable. Remember that we create the physician file first and then try to identify physician practices that those physicians are associated. We created really a global or unique 3P-RD provider ID so that we're able to track the providers over different time. And, some of the things in which you can focus on in terms of policy question includes those that I've listed here. Number of physicians that have a license, number of physicians with active license, active, providing certain care, whether or not their license have expired. So this really gets to a workforce or resource issues for the local community that you're able to kind of tease out. Next slide, please. So I'm just going to highlight a couple of slides here to showcase some of the differences that are coming out of these data files. So in this particular graphic, I'm focusing only on physicians. And here is the distribution of medical specialties. I don't have all the specialties listed here, but this will just give you a flavor of some of the variations that might be happening across different states. And as you can see, there is actually a good deal of variation that is just happening there. So for instance, if you take a look at Massachusetts, one of the things that you will notice that compared to the other states, their share of physicians with a specialty in internal medicine is actually much higher than some of these others. So you have states such as, say, Massachusetts and Minnesota that has that high share. In other states, such as Arkansas and maybe Montana, they are actually dominated with physicians that have a specialty in family practice. Washington is also one that is kind of spiking there a little bit. Next slide, please. So if you take a look at our physician files, again, by different states and break it down by gender, again, you can see some variation that is happening across here. You have a state like Arkansas, that is the first column to the left there. They have primarily male physician, nearly 70%. And then you can see other states such as, say, Massachusetts and Maryland is actually a bit lower. That is, more female physicians seems to be in those states relative to other states. Next slide, please. So here's a slide that focuses again on physician files, but looking at the medical degree and when they obtained them. The green bar indicates that they obtained their medical degree over 20 years ago. So that basically signals an older physician workforce. As you can see from this graphic, there are variations across the different states. A state like Arizona, a little bit more than 70% of their physicians obtained their medical degree over 20 years ago. Then you can compare that to, say, Minnesota, where only 50% have obtained their medical degree 20 years ago. So that will give you a flavor of what the profile of the physician workforce might in fact look like in terms of age distribution. Next slide, please. This slide, just very quickly, focuses on the practice of the physician. Again, the theme here has been that there's variations across states. You have a state such as Colorado or Maryland that by and large, the physician practices there are very high in terms of being a solo practice. So that's a kind of an interesting distribution that you might have there, whereas a state like Minnesota, they seem to be a bit lower and they seem to have larger practices, that is greater than 6 in that purple shading. Next slide, please. So this slide, again, highlighting some of the physician practices component on this. This is the average number of physicians per physician practice sites. I mentioned Minnesota in the earlier slide. As you can see in this slide, their average number of physicians in the practice is actually quite high compared to the other states at 14.2. Next slide, please. A final slide that focuses on physician practices is the common medical specialty among the physician practices. Again, some variation that is happening here. In the first column there, you have Arkansas, where many of their practices, or a good share of their practices, up to 30%, are actually has a specialty in family practice, as compared to, say, Massachusetts, where the majority of their practice has a focus on internal medicine, which is consistent with the designation of the number of internal medicine physicians in Massachusetts that we saw in the earlier slide. Next slide, please. So, so I do have another slide on physician practice files, and this is a share of physician practices with a primary care component. So as many of you might know, primary care is now becoming a greater interest area in terms of workforce issues here. And we put up this slide to kind of give you a sense of what the percentage of physicians with a primary care designation. And so here you can see that Arkansas has the highest one at 53%, but it varies quite a bit, and it could be as low as New York, which is only 33%. Next slide, please. So the final graphic I have here is just to illustrate to you that we also have summarized some of these files in terms of a geographic level. So for the purpose of illustration, this is a physician practice file. And as you can see in this example, we are able to give you information at a geographic level, basically the 3-digit zip code. And there are a number of different characteristics that we have for that 3-digit zip code here. Again, an illustration of some of the information that is really buried in these different data files. Next slide, please. So how is it that you attain the 3P-RD databases? So the first thing I'll mention is that when we created this data initiative, we actually have three separate files for each individual state. Two of them are in fact public use files. The first being the geographic public use file. That is, we are able to aggregate the information at a zip code level or a 3-digit zip code level. That is going to be a true public use file. That is, when you go on the website, you can just download that file. We also will have a physician practice file that will also be a public use file or a PUF file. This is largely a directory of physician and physician practices. It'll have basic information, almost like a phone book, or in the old days, a phone book, but it's really a directory with just basic information that we were able to obtain largely from the state medical board information. There will be no variables that has information from the all-payer claims data or any claims data. Well, I should correct myself. No variables from the all-payer state claims data. There will be some information from the Medicare data. And finally, we will have what we call a restricted use file or a rough file. This will have limited variables from the APCD data, but because of confidentiality of physicians and part of our data use agreement, this file will require a data use agreement. Next slide, please. So how is it that you get this data? The first thing you should do is go to the AHRQ website that is listed up here under Data Innovations. Next slide, please. If you scroll down on that web page, you'll discover there are database links there, and one of them will be the physician research database, the 3P-RD database that is kind of highlighted on the bottom. You'll also notice there are other data innovation databases that we already have on our website, something called the Synthetic Healthcare Data for Research, or CIDR is the acronym that we have for that, and social determinants of health data, SDOH data. Both of those data sources are in fact available right now. So you can go to our website and click on that to find out more information about that. But going back to our physician research database, and may I have the next slide, please? When you click on that link, you'll get to this landing page that kind of highlights that particular data. Next slide, please. As you scroll down, the first set of information you'll hear are these downloadable information that talks about the different methods that we have. There's a data dictionary, there's geographic information, there's the code book for the physician and physician practice file. Now, one footnote here. We're actually releasing the data in 3 different phases. So what is available right now is the geographic level databases. Coming soon will be the physician and physician practice directory. And finally, the restricted use files will come down a little bit down the road. Next slide, please. And so as you scroll down that page, this is the table that you can actually click on these links, and you will get into a zip file where all the files related to that particular state is going to be located. As you can see, we have different formats for your ease of use, whether it's the common separated values, SAS dataset, or Stata dataset. But again, we're releasing the geographic files first, and the physician practice directories are coming second. And then finally, the restricted use files will come last. Next file, please. Next slide, please. Okay, with that, it's a whirlwind tour. So let me see here. Shahu, maybe we can start answering some questions. I didn't have a chance to look at all the Q&As yet, so now I'm gonna do that.
No problem. Herb, thanks so much for you and your team's great work. This is a heavy lift and a tremendous contribution to the field. I can only imagine how much work has gone into that work. So the first question we have is race and ethnicity information available?
Yes. So some race and ethnicity information is in fact available. So one of the things I mentioned is under the claims data, we're actually able to link the claims associated with a physician. And so we provided information on what we call the patient panel. So we do have some information along those lines. To a large extent, I have to check the documentation again and actually consult with my colleague, Zainal Karacha, who is a major technical lead on it. I'm not 100% sure whether or not we have race and ethnicity of the physician. I know that for some state medical board files, that information was actually available. Now, whether or not it made it into this particular data set, again, based on our data use agreement and things like that, whether or not we're able to kind of save that variable. But all the information is in our documentation. And by the way, it was actually made live at about 12 o'clock today. So you folks are actually the first to have that. And again, go down and download all that information, including the documentation.
Thank you. Our next question is, would you please talk about the process that you use to harmonize data and on physician specialty across data sources?
Yes. So that in itself was quite a challenge. As you can imagine, there are some processes where the information might be, in fact, of a self-reported physician specialty that's coming in from, say, the state medical board. And what we try to do is try to harmonize some of that information based on the claims data. What are the patients that are in fact seeing? And another way in which we try to do that is in terms of board certification, right? If you have a board certification in, say, internal medicine, and although you might be listed with multiple specialty groups, we made an assignment based on an algorithm that we came up with. I don't know all the details, as I mentioned before, but it is listed in the documentation that should be on our website. And if it's not in that version of the documentation, we probably have another set of documentation to kind of clarify that. So that's a terrific question, because I think that this audience knows that there's all sorts of complication in terms of making those sort of assignments, because it could be self-designated, but what is it that they really do, right? And that's how come we use the claims data to try to tease that out.
Exactly. Next question is, how are practices defined?
Yeah.
The percentages of physicians in solo practice seem high, at least in California, because many physicians in our state is in the Permanente medical group or other larger medical groups.
Yeah, so that's a terrific question. So once we identify the actual physician files, what we try to do then is to match it up with some of the other information we got from, say, the CMS file, to hone in on a practice. Okay, and that and there we try to group those sort of things together and verify it with claims data in terms of identifying an individual practice. Now, the solo practice component is basically a situation where we cannot quite find an association on it. So, something like in California that might have a large number of folks in Kaiser, for instance, right? I forget exactly how we have done this, but when we get into a location like Kaiser, I'm not sure if we have, I don't recall whether or not we did it by location or by that the entity itself, that is Kaiser. I think we did it by location in terms of that practice, but I would have to check the documentation on it. So in that situation, you only have a practice. You might have a lot of physicians, and then you have lots of them that we couldn't find some information on, but a huge share of it is actually covered by just a handful of practices, right? And again, I invite the audience to actually explore this data and tell us what you find, okay? Because as I mentioned before, when we started this particular effort, we can do some quality checks on it, but we're going to rely on users to tell us how is it that we can improve upon it, right? Because this is, in fact, a prototype, right? We did, so these are terrific questions on that. The details, again, in terms of harmonization and things of that nature, the documentation we have on our website is the source, okay? And if it's not there, feel free to send us an email to tell us, hey, I couldn't find this in the source documentation. How did we do X, Y, Z? Terrific questions, though.
If you offer them a mug, if they find something that is an error.
Yes, absolutely. We're always looking to improve or anomaly. You know, I would say an anomaly because the data is what it is. If sometimes we did our best to pass face validity, but as you know, until you start working with the data, that's when you'll uncover certain components on that. Yes.
The next question is, will the restricted data file contain addresses for physician practices?
I will have to find the what the final data dictionary is. It will have some indication of location, but I'm not sure if the final one will actually have the physical address. So you'll have at least, say, zip code or some geographic component. Now, the biggest reason why we have the restricted file is the following. We want to make sure that the restricted file is used for the purposes of research, right? And that's is going to have a data use agreement that kind of sits behind it. So once you do whatever linkage you want to do, right, in terms of the actual PI, you know, that is the identifier and things like that, you run your little regression analysis and all those good things for it because you're interested in aggregate results. It's not going to be a public use file because we don't want, you know, basically commercial use of the data, right? And that's part of it is that when we got this data source, you know, some of the data use agreements that we have to adhere to falls along those lines. But this one thing will be clear, that you will be able to, under the restricted use file, there will be a clean identifier for that physician or physician practices for the purposes of trying to do those sort of linkages. And eventually, if you probe it long enough, I guess you could find the address. But I'm not sure if we're actually going to release that. So I'll have to think about that.
Great. Next, have you do you have any insights on tracking practices that experienced ownership changes using TIN, group NPI, or other IDs?
Yeah. So we're getting our feet just a little bit wet in this. I know that the research team that looked at this realized that the TIN numbers can be a little bit messy, right? You know, part of it is for us to kind of understand how messy that might be. So for the tax identification number, it's usually used for some commercial purposes and not commercial purposes, but for payment purposes and things like that. So that helps us identify it, but we don't, you know, the final kind of identifier we have for practice is a blend of using information from the TIN versus other data sources as well, because we know that, you know, some entities actually bill under multiple TIN numbers. And what we try to do is, quote unquote, de-identify it, right?
Next, is the data dictionary for the rough file available? Even the rough themselves are not available yet.
Not yet. And that part of it is our conversation with our legal counsel to make sure that we are protecting the right confidentiality and things of that nature. We have to talk to them to make sure that all the data elements that we believe that we can release are in fact released. So we don't actually have the data dictionary quite available yet, because we don't want to say, oh, you're going to get whatever, say an address. And then our legal counsel tells us you can't do that. So so when the files are in fact released, the data dictionary will come with it. So stay tuned on that. So that's a little bit of a longer road, not too long, I hope, but we do have the geographic file and the other directory coming out pretty soon.
Great. Does the data set include nurse practitioners and physician assistants?
Unfortunately, no. Okay, which this is actually a terrific question, because at some point we kind of recognize that that would open up a different area. As you know, as I mentioned earlier on, hospitals represents a huge share of expenditures. The next version is basically physicians, but the potential to start exploring physician assistants and nurse practitioner, that's actually available in the claims data and some of these other data files, right? We haven't had an opportunity to clean that or to refine that sort of thing. But here's a suggestion. I mean, if you are interested in that particular space and you're looking at, say, oh, here's the physician practice data set, it would be really nice if we knew the number of nurse practitioners that are associated with that practice, right? Those are the sort of feedback we would welcome, because that will help refine what the next iteration might look like for us, right?
Thank you. We have a lot more questions, but I have to pick one for the last one. Do you have plans to add new states over time? And do you have any plan to update this at another year in the future?
Yeah.
Thanks.
So this started off as a prototype. So the project is now complete. I think it's actually based on users out there. And if we get comments like, terrific, please add more states, that way we can make an argument to our leadership. Hey, the prototype is successful. You need to fund this. At the moment, we have completed the project, but there is no plans to either replicate or expand. But as the audience sees here, there's great potential to kind of expand this way beyond the 13 states that we have, both in years and number of states.
Thank you so much, Herb. And congratulations to your team and Dr. Karaka too. I think we have to wrap it up very soon. Any final thoughts, Herb?
Well, it was a privilege to present here. Thank you for the invite. We're actually quite excited about this data product. And so please, please, please go to our website, download the documentation, download those files, give us feedback on the email, because we look forward to working with you to make even a better product in the future.
I'm sure many of us are looking forward to using this data as well.
Definitely.
Thanks everyone for attending, and I hope to see you at our next event.
Thank you very much.
Thank you, everyone.
Bye now.